Hello. Today we will discuss topic is about kidney diseases. The kidney is a really important organ in our organism, and usually we have a lot of problems when we have diseases of kidney. And kidney has function like regulation of iron balance, regulation of water balance. Sometimes it may lead to uh, balance to have influence to balance of proteins and so on. And also one of the most important function of kidney is synthesis of erythropoietin and stimulating of hematogenesis. On this slide we may see macroscopical picture of kidney, and the way it looks like brown beans, and usually we have two kidney in normal conditions. But sometimes we may see some anomalies, and we may see duplication of kidney or aplasia of kidney and so on. But in normal condition, kidneys looks like that. We have brown color, and the anatomical layers, there are two main important layers. The first one is cortex, and you may see it in the surface of this part. And in the cortex, we may see accumulation of tubes and glomeruli. And the most important functions will be realized in this part of the kidney. And the second part is medullary part of the kidney, and sometimes we called it like pyramids because they formed pyramidal structures. On this slide we may see the most important histological components of the cortex layer of kidney. We may see glomeruli in this part of the slide, and we may see tubes here. One more, glomeruli and tubes. So when we will discuss some pathological processes, we will pay attention for this histological formation for glomeruli and for tubes. One of the difficulties, the most difficult construction of a kidney is a glomeruli, and it is a vessel constructions which consist from a lot of vessels, and these vessels has important and really interesting structures. We can see some special holes in them, and from these holes we may see realization of filtration processes. Also, one of the most important components of glomeruli is special cells, mesangial cells. Mesangial cells are like a skeleton of glomeruli, and on these cells we may see accumulation of vessels. One more interesting cells are podocytes. They localized on the surface of vessels, and they took a part in the filtration process. It about vessel structure of glomeruli. The second part of the glomeruli is capsula. The capsula synthesized by parietal epithelium cells, and it has name by the scientist who first described it. It's a Shumlyansky-Bowman capsule. And between capsula and between vessels, we can see special place, is special space of urinary. In this place we may see accumulation of a primary urinary, and after that it will lead to tubes, and we may see processes of reabsorption. That's why the primary urinary contain a lot of necessary products like ions, like proteins, and so on. And in the tubes, all these structures, all these products will be reabsorbed. The main function of the glomeruli is the production of ultrafiltrate. Ultrafiltrate is a solution which contains a lot of molecular weight products, like free electrons, urea, creatinine, uric acids, protein with low molecular masses. The volume of ultrafiltrate in hereditary person is something about 200 liters in a day. But the normal volume of urinary of healthy men something about to probably 1.5 liter. So you may see a big difference between primary filtrate and total urina. All diseases of kidney will be manifestate itself by 5 diseases, by 5 processes: glomerular diseases, tubular diseases, interstitial diseases, congenital anomalies, and tumors. On our department, we will discuss glomerular diseases, tubular diseases, and tumor. They are most important for us. But first of all, we should talk about glomerular diseases or glomerulopathia. Glomerulopathy is a special group of kidney diseases which manifestate itself by injury of glomeruli. This process has a lot of different manifestations. It may manifestate itself by like glomerulonephritis, amyloid nephrosis, or nephrotic syndrome. And nephrotic syndrome include lipoid nephrosis, focal segmental glomerulosclerosis or sclerosis, and membranous glomerulopathy. All of these diseases will have same clinical manifestation, and the most important difference will be etiology of the process, localization of it, and outcomes. Glomerulonephritis. Glomerulonephritis is a double-side, non-purulent inflammation of glomerular system of the infectional, allergic, or unstudied nature. So, from this definition, you should remember that it may have really different types of inflammation. It may be productive, it may be exudative. All 7 types of exudative except purulent one. So we can see proliferative and 6 exudative forms. Etiological factors of glomerulonephritis may be divided into groups, like bacterial and non-bacterial. Among bacterial factors, the most important are hemolytic streptococcus, staphylococcus, pneumococcus, and sometimes viruses. In non-bacterial etiology, we should remember about alcohol injury, drug injury, and cold trauma. Pathogenesis of glomerulonephritis include two main mechanisms. It may be antibodies mechanism and mechanism of immunocomplexes. All of these mechanism has 5 stages, and we associated with accumulation and circulation of immune complexes or antibodies and fixed of them on the basal membrane. After that, we may see injury of basal membrane, like accumulation of abnormal masses on it and development of inflammatory reaction in it. After that, we may see proliferation of mesangial cells. After that, mesangial cells start to produce some biological activity substances like interleukins and factor tumor necrosis. And like a result of it, we may see stimulation of inflammation. And in the end of inflammation, we may see two of the most typical outcomes: the full recovery of the process or development of connective tissue and sclerosis. On this slide, we may see classification of glomerulonephritis according to localization of the process. On this slide, we may see healthy glomeruli, and according to classification, glomerulonephritis divides into intracapillary and extracapillary. Intracapillary glomerulonephritis will be associated with localization of pathological process in the territory of vessels and mesangiocytes and all other forms which formed glomerular vessels. Extracapillary glomerulonephritis localized in the space between vessels and capsula, and we may see localization of pathological process here. We will discuss it some later. Intracapillary glomerulonephritis may be exudative and proliferative. All of them will be localized in this part of glomeruli. So it may be associated with infiltration by leukocytes, edema and hyperemia of these vessels. You may see it in all this manifestation in all this part of the glomeruli. Proliferation type, proliferative type of inflammation also may be localized in this localization. It may involve mesangial cells. It may be membrane of glomeruli. Also, it may be mixed form, and sometimes it may be fibroblastic form. Extracapillary glomerulonephritis will localize in this short part of the glomeruli, but this small area of localization will have a lot of problems and will lead to really big troubles with health of patient. It may be serous or exudative, and exudative forms may be siderose, fibrinose, and hemorrhagic, and it will depend on type of exudate which accumulate in this place. And the most typical and most malignant type of extracapillary glomerulonephritis is proliferative one. And in case of its development, we may see formation of proliferation of these cells of capsula, and it will lead to depress of vessels and will lead to development of connective tissue in this place and sclerosis of glomeruli. It process has malignant course and very fast will lead to death of patient. According to course, all glomerulonephritis may be divided into three groups. Acute, and duration of acute something about 1 year, 12 months. This type of glomerulonephritis characterized by benign course. Etiological factors most often are streptococcus, and typical macroscopical manifestation is red or motley kidney. In case of subacute glomerulonephritis, we can see prolongation of this process due to 1.5 years. This glomerulonephritis has malignant course, may be associated with cholera, toxicemia, and all other diseases which associated with chronic intoxication of organism. Macroscopically, it manifested itself by large motley kidney, and this type of glomerulonephritis has unfortunate or malignant course. Most often it will lead to kidney insufficiency and lead to really fast death of the patient. And the third form is chronic. It characterized by very long course, more than 10 years. Etiological factor is immune reaction. Macroscopically, it looks like secondary Wrigley kidney. So, on this slide, I try to show you all general forms of glomerulonephritis and it's a common scheme of its classifications. So, according to localization, they may be intracapillary and extracapillary. According to type of inflammation, they may be proliferative and exudative. All of them have some special forms. Intracapillary proliferative glomerulonephritis will have membranous, mesangial, membranous proliferative, and fibroblastic form, which will lead to formation of chronic glomerulonephritis. In case of intracapillary exudative type, we may see formation of infiltration by leukocytes, formation of edema and hyperemia of vessels, and formation of acute. Exudative extracapillary form will manifestate itself by cirrhosis and fibrinose and hemorrhagic inflammation, and the result formation of acute glomerulonephritis. Extracapillary proliferative type of glomerulonephritis will be associated with malignant glomerulonephritis with formation of semilunes, and it will lead to formation of subacute type of glomerulonephritis. On this slide, I will show you morphological manifestation of acute glomerulonephritis. We can see motley kidney here. We may see small pointed hemorrhagion or small pointed areas of necrosis in the kidney. Histologically, we can see accumulation of neutrophils in this part of the slide, for example, and it is a typical manifestation of exudative inflammation in the glomeruli. Most often it has benign course, and it may have like an outcome full recovery of kidney function. In case of chronic glomerulonephritis, we may see proliferation of mesangial cells or proliferation of cells in the uh, glomerular vessels, and in duration, in some time, it will lead to formation of secondary wriggly kidney. This type of changes associated with the development of connective tissue in place of glomerulus, and you may see microscopical picture like that. One of the most interesting is subacute glomerulonephritis. Subacute glomerulonephritis macroscopically manifests itself like acute glomerulonephritis, motley kidney. But the difference between acute and subacute is the size of the kidney. In case of subacute glomerulonephritis, the size of kidney will be enlarged. So we can see same manifestation. We can see area of hemorrhages here, area of sclerosis, and so on. But the size of the kidney will be increased. On the microscopical level, we may see formation of semilunar formations in the glomeruli. We may see these formations like a result of proliferation of cells, of capsular cells, capsula Shumlyanskого. One more photo for your understanding where is a semilunar formations localized. I hope now it's clear for you. So all of these formations will be associated with squeezing of vessels, and in duration it will lead to formation of hyaline and connective tissue in place of vessels localization. That's why it will lead to unrecoverable processes in the glomeruli. That's why subacute glomerulonephritis has the malignant course. It will lead to irreversible derangement of kidney. We can see development of connective tissue, and really couldn't fix it at all. All glomerulonephritis will manifest itself by three main syndromes, like proteinuria, it's a presence of proteins in the urine, edema, accumulation of fluids in the soft tissues, and myocardial hypertrophy. Myocardial hypertrophy will be a result of disorders in the arterial pressure regulation and increased of functional activity in the heart, like a result of kidney functions injury. Complication of glomerulonephritis may be associated with acute renal failure, cardiovascular failure, cerebral hemorrhage, and uremia. So, acute renal failure will be associated with decrease of functional activity or filtration activity of the glomerulus. Cardiovascular failure will be associated with increase of arterial pressure. It will be associated with hypertrophy of myocardium muscle, and also it will be associated with formations of edemas. Cerebral hemorrhages will be associated with increase of arterial pressure, and it may be associated with rupture of brain arteries, and as a result formation of cerebral hemorrhages. Uremia is a special condition typical for kidney problem, and it will be associated with increase of nitrogen products in the blood plasma. This condition will lead to formation of some inflammatory process in all internal organs. For example, like a result of uremia, we may see formation of toxic gastritis or toxic pruritus, and we may see inflammatory disease of other internal organs. The first damage will be localized on the mucous layers of our internal organs. The next pathological condition which we should discuss today is amyloid nephrosis. Amyloid nephrosis is a pathological process which is associated with accumulation of amyloid in a kidney. And I hope you remember something about amyloid from our previous classes. More often, amyloidosis of kidney is a secondary type of amyloid because it is a result of some chronic infections like tuberculosis, syphilis, rheumatism, or osteomyelitis, chronic abscesses, and so on. This process has four stages. The first one is latent, and amyloidosis and sclerosis in stroma of the pyramids, and the first pathological condition will be localized in this part of the kidney, in its medullary layer. The next stage is proteinoremic stage, and it associated with damage of glomeruli, stroma, and vessels. And we may see a bit number or little number of protein in the urine, and we may see really difficult manifestation of it. But the third stage is more difficult. It manifests with huge proteinuria, and it associated with formation of Siebeck's kidney. And Siebeck's kidney you may see on this slide. The kidney is enlarged, has Siebeck's shine, and solid consistent. And we may see totally accumulation of amyloid. It may be localized in the stroma, glomeruli, vessels, and tubes. And the last stage or terminal stage of amyloidosis is azotemic stage. In the result of azotemic stage, we may see again accumulation of nitrogen products in the blood plasma and formation of toxic injury of all internal layers. Histologically, we may see accumulation of homogeneous masses in the glomeruli, in this part of the slide and in this one. So, you may see difference of the color in this and this localization. On this part of the slide, amyloidosis masses has red color. In this one, only red, only pink one. What is the difference? The difference is the method of staining. In this part of the slide, we may see elective staining, result of elective staining for amyloid. It's a result of staining with Congo red. On this part of the slide, we may see usual histological staining by hematoxylin enzyme. So, you should remember five elective staining for amyloid. They are Congo red and three more reaction with metachromacy phenomenon. They are Hansen violet, methyl violet, iodine green, and one more macroscopical reaction of Virchow. Also, you should remember the typical places of amyloid localization in the kidney. They are stroma, vessels, glomeruli, and tubes. On this slide, we may see manifestation of all these localization. On this glomeruli, we may see accumulation of totally accumulation of amyloidosis. On this slide, on this glomeruli, we may see partial accumulation of amyloid in the glomeruli. Also, we may see accumulation of amyloid in the vessels here, and some amyloid in the tubes, you may see it here, and in stroma we may see fibrils of amyloid between all anatomical structures of kidney. I marked amyloid for you, and you may see it in the slide. I hope it's clear for you. Now, the outcomes of amyloidosis in kidney associated with acute renal failure, chronic renal failure, nephrogenic hypertension, and autointoxication. Acute renal failure associated with damage of glomerulus, chronic renal failure associated with formation of constriction of glomeruli and development of connective tissue in the kidney, nephrogenic syndrome associated with prevalence of protein in the urine, and autointoxication is a terminal stage of amyloidosis of kidney, and it's associated with accumulation of nitrogen products in the blood plasma. The next pathological condition which we should discuss today is nephrotic syndrome. Nephrotic syndrome includes three components or three nosological forms. It may be associated with lipoid nephrosis or disease with minimal changes. It's the same name for this process. The second process is focal segmental glomerular sclerosis or glomerulohyalinosis. It's really closer definition. And the third one is membranous glomerulopathy. Lipoid nephrosis or minimal change disease is disease of small spots of podocytes. So podocytes is a special cells which localized on the surface of vessels in glomeruli, and it formed a special cage which take a part in the filtration activities. And in case of damage of small parts, we may see appearance of abnormal products in the urine. For example, it may be fats, proteins, or some other substances. But the most typical and most important for us is fats accumulation. One more photo with podocytes and the small pods you may see in this part of slide. So it's an electron microscopical picture, and it's really beautiful picture and beautiful cells which formed in our glomerulus. There are a lot of these cells, and it's amazing to understand that the disease of all these little substances will lead to really difficult conditions. On this slide we may see scheme of kidneys filter, and we may see surface or lumen of blood vessels, and so arterial wall, and under it we may see podocyte and its small pods. This one is large pod of podocyte and this one is little pods of it. And we may see that small pods of podocytes is a part of filter. We may see that in result of damage, we may see a large space between neighbors podocytes pods, and it will lead to formation of abnormal products in the urine. Macroscopically, lipoid nephrosis manifests itself by large white kidney. Histologically, we can see fatty degeneration or fatty dystrophy in the epithelium of tubes. Outcome is chronic renal failure. On this slide, we may see accumulation of fats in the epithelium cells of connective tubes. I marked it for you, and the typical question on exam is why these epithelium cells looks like empty. They looks like empty because we use usual histological staining with hematoxylin-eazine, and as a result of contact between fats and alcohol, we may see disappearing of these fat masses. The next pathological process is focal segmental glomerulohyalinosis or sclerosis. It manifests itself by some glomeruli show partial or segmental hyalinosis, like in this part of the slide. We may see this part is damaged, we may see development of helinosis and accumulation of hyaline in this part of the slide, and this part of the glomeruli is healthy. We may see healthy vessels here. And this disease has unknown pathogenesis and unfavorable prognosis. We really don't know how we should treat it. Membranous glomerulopathy. It's autoimmune reaction against a non-renal antigen and associated with immune complexes, associated with thick basal membrane of vessels and basal membrane of glomerular basal membrane, and looks like membranous glomerulonephritis. We can see damage of this part of glomeruli. The next big group of diseases is tubulopathies. Tubulopathy it's a disease which characterized by the predominance injury of connective tubes and epithelium of tubes in kidney. So in this slide we may see healthy tubes, and we should see that all the nucleus localized in one level and localized on the all of the epithelium cells localized on the basal membrane. And in case of pathology, we should find the pathological process in these red areas. Tubulopathy may have two main type of course. For example, it may be acute and chronic. Acute course of tubulopathy associated with development of acute renal failure or necrotic nephrosis. And we may see all typical manifestation, morphological manifestation of necrosis. For example, it will be disappearing of nucleus, loose structures, components of epithelium, and so on. Chronic course will be associated with myeloma kidney and Gotti kidney, and it's typical for really difficult chronic disease like myeloma and Gotti. And in our department, we only should know that they exist. Acute renal failure is the most important for us, and it's a syndrome which morphologically looks like acute tubular necrosis. We may see disappearing of nucleus and loss of structure in cells of epithelium in connective tubes, and it is a typical manifestation of histological manifestation of this process. Macroscopically, we may see picture of shocked kidney. Shocked kidney looks like pale cortex and dark pyramids. It's typical morphological manifestation for acute renal failure. One more photo, it may be associated with not only with not full injury of all epithelium cells in the tubes, but sometimes we may see some healthy cells and some cells with damage, like in this part of the slide. So disappearing of nucleus and losing of structure of cells is the most important component or most important manifestation of this pathology in a kidney. Pathogenesis of acute renal failure may be direct and indirect, and I hope you remember it from our class about necrosis. Direct cause may be associated with nephrotoxin substances influenced to epithelium. For example, it may be some salts or some poisons which patient get with food or with water and so on. And also it may be indirect forms, and most typical cause is ischemia due to miscarriage of blood by shunts. And we may see macroscopical formation typical for shocked kidney. I want to show you it again. It's dark pyramids and pale cortex. This pathological process has three stages. The first stage is shock kidney, and it is associated with collapse of capillaries of glomeruli, dystrophy, mostly it will be protein dystrophy in the tubes, epithelium, and the second stage, the most typical morphological manifestation of it we may see on the previous slides, it oligoanuric stage, and it manifested itself by necrosis of tubes epithelium and edema or infiltration of stroma and so on. And the third stage is stage of regeneration or recovery stage, and it characterized by hyperemia of glomeruli, regeneration of tube epithelium, or focal nephrosclerosis. And the outcomes of acute renal failure or shock kidney will be associated with duration of the process and the conditions of basal membrane. This basal membrane is a place on which all epithelium of kidney tubes localized, and if we see rupture of it, it means that recovery is impossible. But if it healthy, we can see full recovery of a kidney epithelium, and this process takes something about 3 weeks. In 21 days, we may see full recovery of kidney function. Outcomes of renal failure may be different. It may be recovery or it may be uremia. So I have already told you a few words about recovery process, and uremia is a typical process which typical for kidney diseases, and it is associated with accumulation of nitrogen products in the blood plasma. Chronic tubulopathy associated with two difficult diseases like myeloma and GORD, and it will lead to chronic injury of epithelium of tubes and formation of chronic renal insufficiency uremia. And in the terminal stage, we may see all manifestations of uremia in all internal organs. And in the end of our lecture, we should talk about renal cell carcinoma. Renal cell carcinoma, or it's malignant tumor from epithelium of tubes. So only one source of growing malignant tumors or cancer in the kidney is epithelium of connective tubes. The etiological factors is smoking, hypertension, cadmium exposure. Manifestation of this disease associated with hematuria, with macrohematuria when urine becomes to red color, abdominal mass, you may see formation of some infiltrate in the abdomen, and flank pain. And one of the typical characteristics of this disease is a bad prognosis. If we can see metastasis, the 5 years survive less than 5%. The most of patients is incurable, and it will lead to the death of them. And the last topic is pyelonephritis. Pyelonephritis is inflammatory disease of kidney which associated with infections of urinary tract, and more often it has upper way from the bladder to kidney or pelvis, and we may see formation of suppurative inflammation and formation of scarring in place of necrosis. The first morphological manifestation is formation of suppurative inflammation. After that, we may see necrosis, and after necrosis, we may see scarring formation. The most typical etiological factors is Escherichia coli, Proteus, and typical manifestation is fever and flank pain. You will discuss it more closer on the department of urology, and you will know more about pyelonephritis. So now thank you for your attention, goodbye and good luck.